when the Access program was announced, my immediate thought was Omada. It just felt like a pretty natural program given your clinical results and what your focus areas are. And so I'm kind of curious what the thinking about Access has been internally from your perspective.
Yeah, for sure. Um, I'll give you kind of the high level gist, and then feel free to double
Yeah.
click on anything. But um, Sean's been working on the policy stuff. We'd been aware of something that was going to be happening, and so we were exceptionally pleased with the overall like thesis of access. It from a modest perspective, it's hard to argue. You got above 65 beneficiaries that didn't have access to a form of care that obviously we specialize in and we believe is super super important to chronic condition care that realistically would have been really really difficult for them to have access before access, I guess, pun intended, that your under 65 commercial population has pretty broad access to. So there was this asymmetry. So that was number one. Thematically, we're like super pleased. The second one goes without saying, obviously, chronic conditions, clearly the area to work on because of the prevalence, the cost, the debilitation, the constellation of negative impacts from comorbidities related to chronic disease. So that's number two. Number three, the whole idea of trying to get um, digital health providers to work alongside in-person providers. That kind of connection has eluded, for the large part, the virtual and digital health markets, as well as the legacy traditional market. So we really love that thematically. The other part of the thesis we really, really appreciated was the idea of this, like, outcomes approach. We interestingly have deals today where, the provider organizations we work with pay us a certain amount, which is much lower than our total fee. And then based upon outcomes, they pay the full balance of the remaining amount. It sounds very much like access. And so we saw the framework, we saw the thesis, we saw the general nuts and bolts of this, and we're like, hey, we've not only done this before, but we've actually done trials in the senior population, and the outcomes are pretty darn good. And Alex can follow up and send you those trial data. So strategically, you're right, felt like a really good fit for us. And so we're right now evaluating the operational implementation aspects of it and saying, gosh, okay, great. We love the thesis. Do we love the operational mechanics of it? And I think that, there's more than 100 pages for us to go through. We haven't yet decided whether or not this is a true go for us or not. But we're looking at the multiple points of scale that are required to truly make this a sustainable business. And we can talk about that if you'd like, but we're evaluating that right now. So that's kind of our general take as it stands today on February 19th.
And any reaction from you all on the rates? I know like the general reaction in the industry was they're too low. I kind of did some
Yeah.
back of the envelope math and didn't seem crazy for Omada in the CKM track, but I'm curious if there were, sort of any initial reactions you had there.
Yeah, you're right. That's the general external consensus right now from multiple people is leans negative on the rates. And I think I hypothesize, Martin, it's because people are trying to back in or shoehorn existing models into those rates. And I think that's probably why there's this cognitive disconnect. When in actuality, it's probably a little bit of this, like, hey, listen, we've got to kind of like change what we do to get into those rates and to make this possible. We being the general healthcare system, as for Omada, how we perceive the rates, I mean, we're still in our analysis, so it wouldn't be, prudent nor responsible for me to say what we actually think about the rates because we're still working through all that stuff. I can, kind of pull back or lift the hood up a little bit and share with you kind of what we're looking at. I think there's multiple points of scale, and I think that's what it comes down to. The first point of scale is around the unit economics. I do believe, and others have said this, that technology, namely AI, will need to play a big role. We know that AI can work in senior populations or technology. We've done those studies. We've done the market research. It is a fallacy that seniors are not comfortable with technology. It's just not true. We've not found that to be true, at least with the technology we use with them. However, we know that AI enabled human care is probably the sweet spot for above 65. Um, and so there's a unit economics piece that we've got to study around that. Like, what's the ratio and balance that works and is engaging for the above 65 group, but at the same time fits in the unit economics box that has been prescribed from a rate standpoint. The second point of scale is, and this is not just for Omada, this is for everybody, is that if you're only operating inside Hot Springs, Arkansas, you probably don't have a scalable, sustainable business. So the other point of scale is like, can you get it from Hot Springs, Arkansas and in Manhattan or in Dallas, Texas, or in Portland, Oregon? So across all 50 states, like, can you do that level of scale sustainably? And then the third is really about patient acquisition, right? You've got simplistically two players. You've got like a digital healthcare provider like Omada, then you've got like your in-person provider, and like who's taking on the burden of patient acquisition. And so the question is like, okay, great. You're a provider, you get a fee for reading the data. You know, an Omada-like organization gets the provider service care delivery fee. But then there's a cost inside the unit economics kind of boundaries that has to compensate for patient acquisition. And oftentimes that can be quite expensive. So that has to be sorted. And so we're looking at all that stuff right now, but that's how we kind of look at the unit economics and what we're looking at. And it all relates and it goes back to those 3 points of scale.
A talk track that we've heard from CEOs, including Sean, in earnings calls recently, is a focus on how they're using technology to help, change and scale the operations of a care delivery company like Omada. I was wondering if you could talk about anything that you're seeing where you're noticing technology have an impact on that ability to scale.
Yeah, I mean, if you take Omada as a case study, there are 3 areas of technology, and I'll talk specifically about AI. And AI I'm talking about is less about machine learning and algorithms. That's a different conversation. I'm talking about more of the big frontier models with the generative AI. It really falls in 3 categories for us. There's more than 3, but I think there's 3 big ones. The first one is probably, from a patient care standpoint, the most important one, which is what is the agentic experience. And last year we launched Omada Spark, which is our AI healthcare assistant. And for the time being, it's focused on 2 areas, one of which is nutrition, because we know everybody eats, and food is probably the most sensitive factor when it comes to the chronic conditions that we care for people. And really the thesis there is not only 24/7 access, but it also real-time accesses your patient profile to know that if you're allergic to peanuts or you have diabetes, that it's not going to recommend something that's inconsistent with that. And in fact, it's going to go the extra step and recommend something that is consistent in accretive to good care for those particular constraints or conditions. And we launched that. We're seeing pretty good uptake. We're happy with what we're seeing, and we're scaling that approach throughout, because why ask our human care team simple questions about recipes, nutritional density, calories, and all that, when they should be focused on actual care? And our nutritional AI can actually just hyperdrive or enable and amplify that conversation, not only in its content, but its speed. And so that's kind of the biggest area. Then the second area is, how do we drive efficiency with our care teams? Martin, that we have a belief that has not changed, that humans create trust. Human interaction creates trust. And trust is the currency for behavior change. And we're a behavior change company. that focuses in this time between visits so that when you see doctor, on visit 1 and they tell you to do A, B, and C, that we can actually pull that through on a day-to-day basis so you're successful on doctor visit 2. And so that ability to utilize AI to help our human care teams be more efficient. So for instance, last year we launched context summarization. So Martin, let's say you are a certified diabetes educator or you're a coach. You may have hundreds of patients you're caring for, and Wei-Li comes up on your list, on your panel as, having something that is urgent. And you've been treating me or helping me and caring for me for 2 years. Do you want to take 20 minutes and scroll through, 20 years of messages and labs and all that kind of stuff? No, you're going to hit the AI agentic context summarization tool. And you're going to work with that summary to help you get a quick understanding, because there's an alert that's probably just happened, like a high blood glucose reading overnight. And you want to get that context as quickly as possible so that you can help me. And so that reduces what I call care preparation time. It increases actual care time. And so that's number 2 area where we're working with, and we're extending that this year over to member services and the like. And the third one, of course, is because we're a technology organization, we're a healthcare organization that has heavy technology, as you know, is with our engineering group. Over 90%, which we should expect now, of our engineers are using Copilot tools or cursor tools to streamline and increase the productivity of actually line code and code capacity, pushing it out the door into our releases. And we're seeing significant productivity gains in that area. So those are the 3 areas. There's some other areas too as well, but those are the 3 dominant areas.
And I think, where I kind of want to end the conversation on is there's some news today from Omada about Omada for cholesterol. Can you talk a little bit about the origins of this program? Was this mostly demand from clients? What prompted this new development?
Yeah, we're excited about the expansion of our cardiometabolic platform to include cholesterol. Truth be told, because we treat multiple cardiometabolic diseases, hypertension, diabetes, prediabetes, obesity, our studies would show that we have an impact on cholesterol. So this was a natural extension from a clinical standpoint. But most importantly, our strategic approach to expansion, whether it be a new product, a new device, a new area, a new service, new feature, is really in response to our customers. And so we had some very large customers come to us last year when they were looking at all of their employees and looking at the top areas that were driving their healthcare expense and also plaguing their employees. Cardiovascular continues to come up. And we'd already been in hypertension and diabetes and all that. And so it was a natural extension for us to work with our customers and actually build out this expanded cholesterol program within the cardiometabolic suite. And so very much a pull from our customers. And so we're over the moon to be able to provide that to all of our client base today, as well as our new clients that will close this year.
And can you talk a little bit about what the program looks like for, let's say I unfortunately have high cholesterol, like if I was enrolled if my employer was an Omada customer, what it looks like?
Yeah, absolutely. So the experience, and this is by design and by intention, Martin, the experience you have coming in. So the moment you enroll and you set up your account, whether it be for prediabetes, obesity, diabetes, hypertension, cholesterol, whatever it is, even MSK, you'll go through a very similar onboarding process. And basically what that is you'll come in, we'll verify all your information, all your insurance information, just like when you go to a regular doctor's office, because we're a provider. And then we essentially will introduce you to a care team. And your care team will know what conditions you have. In this particular case, you have high cholesterol. Let's say that's the only thing you have. You're relatively fit, you're trim, but you just have high cholesterol or something wrong with your cholesterol profile. Your care team, we notify that, and you'll get assigned a care team, and they'll begin to reach out to you simultaneously. You'll be put into a peer community of individuals just like yourself, and we'll begin you on a care track or pathway within our program that is specifically constructed for your particular condition state around cholesterol only, and that will start the actual experience. And so your coach will work with you, and then your care pathway will change as a result of that. And then to bring it full circle back to Omada Spark will begin interacting with you around nutrition, because nutrition is a huge part of obviously changing your cholesterol profile, as is statins or other medication. And so that's generally what the experience will entail. But that experience is somewhat similar to all the experiences of all our products, not because of the same program, but because the science of behavior change basically says that if you have human support, you have goal orientation, you have a community of support, you have accountability through your human coach and devices like real-time biofeedback, and then you have essentially a learning path, that you have essentially created the environment for behavior change. And so we deploy that same structure across all of our programs, and then now, of course, new to our cholesterol program.